Hello everybody and welcome back to the SimKit podcast. Today we're going to be talking about procedural skill and the practicing of procedures. Really what we want to talk about is procedural skill decay and how to not suck at procedures you do rarely. And specifically we're going to be reviewing and referencing an article out of the Annals of Emergency Medicine by Schneider et al. Titled Mental Practice: Applying Successful Strategies in Sports to the Practice of Emergency Medicine, published in August 2024. Now, normally I keep the educational content of this podcast and what SimKit offers separate, but this topic is so near and dear to my heart, well, we made an entire company around it. And what is the it here? Well, it is maintaining skills in high acuity, low occurrence, or halo procedures. These are procedures that are infrequent enough in clinical practice for your skill in them to decay if you rely solely on touch points in emergency medicine patient care to maintain yourself and your competency. And Dr. Schneider's article is a must-read for any emergency physician interested in this topic or anyone worried about their procedural skills. So with that said, let's dive into this article. Again, it's titled Mental Practice: Applying Successful Strategies in Sports to the Practice of Emergency Medicine. And we're going to break it down into concept introduction, evidence in sports, evidence in neuroscience, evidence in healthcare, and best practices in mental practice. So, in their introduction, they review the similarities between emergency physicians and professional athletes working in high-pressure situations with high stakes, high emotions, and the need to perform at a near-perfect level. And you can tell that Dr. Schneider and his author group really understand this issue well. In their introduction, they state the following, quote, "Especially important in EM, the mandate of which remains to be prepared for anything, anytime, anywhere, is the achievement and maintenance of competency in those potentially life-saving skills that are high acuity, low occurrence. Examples of these high acuity, low occurrence skills abound, particularly with respect to procedural competency. Take, for example, procedural cardiac pacing as a skill within the EM repertoire." End quote. This article notes difficulty for many physicians in maintaining the skills in such procedures, stating, quote, "Not all emergency physicians have readily available access to task trainers, simulation centers, and team-based instruction, or adequate time to achieve this level of learning." End quote. Now, in looking at the status quo of maintaining skills in these rare procedures, the authors get a little punchy and a little direct. They go on to state, quote, "To rely on these high acuity, low occurrence events occurring enough in practice to even maintain these core competencies is insufficient and irresponsible." End quote. And I just want to give kudos to these authors for calling it out, for calling out what seems to be common practice in our specialty, but truly should be thought of as unacceptable, and as they said, even irresponsible. They make further reference to this status quo, stating, quote, "Reading or passive learning modalities such as videos or podcasts are convenient and inexpensive, but relatively lower yield compared to active learning modalities." End quote. They highlight, and certainly most educators in emergency medicine agree with the fact that we need to practice these halo procedures at interval. From here, the natural thought would be towards simulation, but we all recognize cost, time, and inaccessibility constraints that limit our ability to use this modality. The authors talk a little bit about VR too, but they note that in its current form, it is also somewhat limited, again, by cost and availability. The authors conclude that, quote, "A middle ground that is engaging in preparation but less resource intensive is necessary to fill this competency maintenance gap, as well as learning new emerging procedures and skills." End quote. And this is where the authors introduce the concept of mental practice, which we're going to spend the majority of the podcast talking about today. But this competency gap, let's pause there for a second. This competency gap and filling it is exactly how SimKit came to the fore in delivering procedural training to emergency clinicians. Every month, the clinician gets a box in the mail with 30 minutes of practice in high acuity, low occurrence, or halo procedures. In doing so, the barriers of entry referenced by these authors particularly cost, time, and accessibility, are significantly reduced. Feel free to check out the video in the show notes to see what we mean. Now, back to our article and mental practice. The authors define mental practice as the cognitive rehearsal of a task without physical movement. They talk about mental practice being really a very deliberate process of an imagined physical performance of an event or a procedure with a focus on the mental imagery, the imagined kinesthetics, and even the emotion of a situation, event, or in our case, a patient care scenario. So let's talk about evidence for mental practice in sports. In keeping with the comparison of the performance of an emergency clinician and a professional athlete, they talk about the evidence for mental practice in sports. So what is that evidence? The first thing the authors make clear, and appropriately so, is that physical practice of a skill is really the ideal form to gain mastery and performance. If physical practice is not a viable option, mental practice may be a reasonable alternative. What they see in the sports literature is that mental practice has the best outcomes in what are called closed skills sports scenarios. These include very predictable performance measures like a gymnastics routine, a golf swing, a hockey shot, etc. What they note is that the literature is most supportive of mental practice in sports skills that have a really high cognitive component compared to tasks that are purely physical or reactive. Here they draw similarities between a golfer taking a chip shot from a sand bunker and an emergency clinician floating a transvenous pacer. There are a lot of visual, spatial haptics that go into the performance of these tasks and a great deal of mental processing prior to and during execution of the task. Importantly here, when doing mental practice, these authors recognize that the motor imagery, the concept of visualizing, and in some instances even stating aloud in great detail the physical steps of a performance, is a necessary step in the process of motor execution. So what evidence do we have from sports to support mental practice? The authors cite a 2020 meta-analysis noting that mental practice has been shown to be more often used by experienced or expert athletes compared to novices. They also note that the duration of an effective mental practice session is somewhere in the 20 to 30 minute range. And confirming what is already known through the cognitive science literature of spaced repetition and deliberate practice, the sports literature suggests a greater benefit from repeated and deliberate use of mental practice training. Now, moving from the sports literature to the neuroscience literature, we see that functional imaging studies show overlapping areas of neural activation during mental practice and motor execution, implying certainly some degree of shared neural correlation. This neuroscience literature suggests that mental practice can fine-tune the processes of future motor performance, resulting in more effective predictions and motor execution of tasks. That's pretty cool. The neuroscience literature actually highlights that motor imagery is a necessary step in the process toward motor execution. And there's a really nice graphic in the article, which is reproduced in the show notes, that shows the spectrum or steps to motor execution. The first, in initiation of the action, we actually have to mentally simulate the action in our brain before executing it physically. All right, so what evidence do we have for mental practice in healthcare? The authors note that there have been multiple studies that show improvement in skills acquisition in different areas of healthcare, including performance of a cricothyrotomy, laparoscopic suturing, bronchoscopies, and hysterectomies. They point out a 2015 meta-analysis with 9 studies. 5 of them showed favorable results and 4 having neutral results. The aggregate of the data suggests that mental practice is most beneficial when run in parallel with physical execution of the skill and when used by veteran clinicians who have some baseline knowledge on the skill being practiced. And very, very interestingly and importantly for us, with these halo procedures, mental practice has been shown to improve or decrease the stress response. Now, this is hugely important when it comes time to cut the neck for a cric or to drain that pericardial effusion. It is, of course, important to point out that mental practice is not without its own limitations. When looking at non-technical skills, the data is less robust. In a 2020 systematic review of 8 studies, only 3 demonstrated benefit for non-technical skills, whereas again, most demonstrated improved technical performance when evaluated. This highlights again probably the niche for mental practice in procedural performance, particularly for low occurrence procedures. Okay, so what are the best practices, or how do we use mental practice to its fullest potential in emergency medicine? Again, the authors want to highlight that mental practice is not superior to, or probably not even equivalent to, clinical experience and active learning with things like simulation or task trainers. It seems to have a specific benefit in maintained touch points with procedures and spaced repetition to combat skill decay between simulated training events. The ideal scenarios for the use of mental practice are for those high acuity, low occurrence procedures where there is a high cognitive component to the execution of the task and there is an emotional charge or significant stressful nature to the performance of the task. Appropriately, the authors take a giant step back before talking about best practices in executing mental practice. The first thing the clinician should do is engage in the 4 steps of addressing their, quote, subpar competency, end quote. These steps are contemplation, planning, action, and maintenance. So step 1, contemplation. The clinician needs to take a step back, catalog all the procedures they are responsible for doing, and think about the last time they practiced one, did one, or even mentally simulated one. They need to acknowledge in some of these areas that they are no longer competent. After recognizing this competency gap, step 2 is preparation, where they prepare to refresh or regain competence in the skill. One tool in doing so is, of course, mental practice. Step 3 is action, where they create and execute plans for increasing or regaining that competence, and then once they've done so, they move on to maintenance, which is, of course, maintaining this newly refound competence. So how do we do this? One evidence-based approach is what are called mental imagery scripts. These mental imagery scripts are, in their essence, a procedure or physical task written down in paragraph form and broken down into 3 different categories of cues meant to enhance the mental imagery, which are visual, kinesthetic, and cognitive. The text of that mental imagery script can be color-coded by these different cues so that the clinician, when completing mental rehearsal and mental practice, can work through and visualize, verbalize, or even physically execute through pantomiming these different cues. Now, recognizably, this is a time where a picture's worth 1,000 words, and a mental imagery script for cricothyrotomy is in the show notes for your reference. Now, in the medical literature, there exist many mental imagery scripts, some of which are validated with evidence, but the authors point out one challenge here is the lack of pre-existing scripts for many emergency medicine procedures. I will say, after reading this article, we at SimKit have created mental imagery scripts for each of the procedures we teach. So the question there comes, if a mental imagery script does not exist for a procedure or scenario you are looking to regain competency in, what do? Well, one approach is the PETTLEP, PETLEP, or Physical, Environmental, Task, Timing, Learning, Emotion, and Perspective model. In this model, the practitioner addresses components of the procedural execution in each of these 7 elements. Again, an example of the PETLEP model for cricothyrotomy from the article is reproduced in the show notes for your reference. So, as we're saying, after doing your catalog, your look in the mirror, and identifying the procedures where you feel like your competency has waned some, the next step would be to recognize or find one of these mental imagery scripts or create a PETLEP model in review of these procedures, and then Create a spaced repetition every month, every few months, setting aside 20 to 30 minutes to do a mental practice of this procedure with that model. Okay, so what is our summary and what are our take-home points from this article on mental practice in emergency medicine? We recognize a shared performance environment with many professional athletes who have to perform at a high level with little or no mistakes in an emotionally charged environment. Drawing from the sports literature, we see benefit in mental practice, but recognize that it's not really a replacement for physical training and really should be an augmentation tool for spaced repetition and skilled maintenance. The authors note that we as a specialty should acknowledge when our skills have decayed, which is especially true in HALO or high acuity low occurrence procedures where clinical practice is simply not enough to maintain skill. They recommend using the PETLEP model or mental imagery scripts in 20 to 30 minute segments of training or practice in a spaced repetition format. I would recommend all who are listening to think about the 4 stages in the process of addressing any potential subpar competency you might have: contemplation, planning, action, and maintenance. Realize that the first step in addressing a skill or competency gap is to recognize that you have one, and it is okay to have one. Emergency clinicians are tasked with knowing nearly all areas of medicine while simultaneously having to maintain skills as a resuscitationist and competency in rare life, limb, or vision-saving procedures. This is a Herculean task that none of us are perfect at. If it feels overwhelming or daunting to you, know that you are not alone, and SimKit is here to help you feel and to be confident and competent. Take a look at what we are doing to try to address procedural skill decay in emergency medicine with the video and links below. But if there is anything we can do to help you in your journey to competence, know that we are here and you can reach me, Jason Hine, directly via email jason.hine@simkit.co. Take some of the information from this podcast and this article on mental practice and apply it to areas where you feel less confident or you need a refresher. We hope you take and apply some of these concepts presented in this article and podcast on mental practice, but also more globally on procedural skill decay, space repetition, and skill maintenance. You will notice a significant change in your confidence and willingness to provide care for those critically ill patients in your department. Thanks for listening.